Welcome to our second session on Acutherapy. I'll try not to choke and gasp from this new carpet today like I did the other day. As you saw in the first demonstration of Acutherapy, just your light touch, when properly applied, makes dramatic change. And all you saw in the first demonstration was a few points on the neck and the head, the face. We're going to continue now today with a discussion of the shoulder girdle. We're going to do a little bit of review of the anatomy of the shoulder girdle, and we're going to talk a little bit about body mechanics. We touched on it last time. Now we're going to try to demonstrate to you how dramatically body mechanics affects the way we feel. And then we'll show you a demonstration of applying Acutherapy to the shoulders, and so that you can begin working on people now with a variety of shoulder complaints and shoulder pain. We talked just briefly yesterday about the Golgi tendon apparatus. I want to explain some things to you about it today so that you'll have just a little clearer view of the massage therapist's understanding of the function of the Golgi tendon apparatus and how we work with it. As I told you the other day, there's a Golgi tendon apparatus at the end of each muscle, and it's in the ligamentous or tendinous tissue at the end of the muscle. And if you'll recall, all muscles are connected to the bone via ligaments, or they're connected to tendons. And this gives us the ability then to move our skeletal structure about. The function of the Golgi tendon apparatus is a monitoring of the tonus of that particular muscle. Now, it's important to realize that a muscle must never be totally flaccid or totally relaxed, nor must it be in a total state of contraction. But it must maintain a normal tonus. And to us that means that it must remain just tense enough to maintain body posture, but not so tense as to pull the posture out of alignment. In all my years of lecturing to chiropractors and other doctors, I get a big kick out of reminding them that muscles move bones. Bones do not move muscles. One of the things that the body worker does, the muscle therapist, is to relax muscle tissue in order to allow bones to go back to their normal positions. I'd like you to think about that for a minute, because we're used to talking in terms of a chiropractor finding a bone, quote, out, unquote. Whatever out means to us in our vernacular. I have clients come into my office all the time and say, my neck's out. Well, it's out of what? You know, well, the bone is out right here. Well, it may be or it may not be. And they say, can you fix it? And if I say, sure, it's tantamount to implying that I'm going to do a chiropractic adjustment, when in fact what I'm going to do is a muscle manipulation, relaxing muscle tissue in order to allow the bone to go back into its normal position. And it's really unlikely that one vertebra would be out, so to speak. The more usual case is that the meniscus, the small muscles around the vertebra, and the larger postural muscles would be tense or in spasm or in a state of, quote, permanent contraction, meaning that the contraction is permanent until some correction is made. And that correction is up to the muscle therapist in order to allow that muscle to go back to normal. And that tension must be relaxed in some method in order to allow the tension to be relieved on the nerves and make the person down. And it's not really pinching as you would think the nerve caught between two bones. And in fact, the likelihood of a nerve being caught between two bones is so remote as to be almost ridiculous. The only time that in my mind's eye, I could see that is if the intervertebral space was non-existent, meaning that the disc is gone, totally degenerated, and the two vertebrae are sitting right down on the nerve ganglion. Then we would have what could be considered a pinching. But it feels for all the world like a pinch when we have that kind of a pain. And so today what we want to do is address some of that. Let me go to the board here for just a minute and give you an overview. Those of you who have listened to your tapes on stress strain or have sat in on our stress strain lectures here, this will be old stuff to you. But I think it behooves us to review it for just a minute. Stress comes to us in many ways. Moving our classrooms here the last week has been stress to the nth degree. We can have emotional stress and we can have physical stress. And we're not going to go into that variety of stressors in this lecture, but what we are going to do is remind you of what that stress can cause. Stress, when it goes beyond the elastic limits of your body or my body, and remember that each of us have a different elastic limit, meaning that we can perform a function with muscles, you see, like this, over a given period of time with a given amount of weight in there, and it would work the muscle within its elastic limit and no harm would be done. But if we overload that muscle by lifting too much weight and or going too many times, we would cause muscle strain. Now, strain simply means that we have tension in the muscle that can't relax. It becomes what I have come to term a permanent contraction. That permanent contraction, and I always quote it, that permanent contraction means that the body of its own accord cannot relax and release that muscle that's in a state of strain. It may or may not be in a total spasm. It can be, but it doesn't have to be. This muscle or group of muscles that are in a state of strain now must have something done before they can go back to total relaxation. Now, if we think for just a minute about the function of the human body and we separate it into its different systems, we think of the skeletal system as that framework that holds it up. We think of the muscular system as those organs that move the body about and hold it in balance. We talked a little bit about that last time. So the muscle's job then is to move the skeletal system. So if a muscle goes into a state of strain, depending on the degree of that strain, we may have a distortion. We'll always have a distortion, but depending upon the degree, it may become a very obvious distortion. So the next step then in our stress-strain syndrome is distortion. Distortion means the body pulled out of natural and normal alignment. Okay? Now, it's important to note that the body must stay over its center of gravity, and we'll cover that in a few minutes. But knowing that tells us that as we stand, if we twist a little bit, an adjustment will be made in the body to hold us over our center of gravity, else we would fall down. So then when we have distortion, we very often develop compensatory distortion. So down here as a sub-bracket to distortion, allow me to put compensatory. distortion. Meaning now that a muscle has gone into a state of strain, and if that strain is dramatic enough, it tips or twists the body out of alignment, causing it to stand off balance. The body's own autonomic system in reading how to maintain balance will tighten opposing muscles to pull us back into balance. And when that happens, we get compensatory distortion, because now we're twisting the body back around to stay within its center of gravity or over its center of balance. When that happens, then we begin to have other muscles who are compensating for this original strain begin to overwork. And overwork is one of those stressors which caused this strain in the first place, probably. So the compensatory distortion now begins to cause secondary strain in opposing muscle groups. And as this whole process begins to happen, then an interesting phenomena takes place, and that's called fatigue. And the reason fatigue sets in is because muscles are now being overworked and not allowed to rest when we stand comfortably or sit comfortably or even lie down. And the reason they're not allowed to rest is because the original strain is a tension that can't relax by itself. And because it can't relax by itself, it remains constantly in strain. How many of you right here have gotten out of bed in the morning just as tired as when you went to bed at night? Look at the hands go up. Do you see? Why? Because you have overworked your body, both physically and emotionally. And by overworking it both physically and emotionally, strain and distortion and compensatory distortion has set in. How many of you have talked to a doctor and said, "Doctor, you know, I don't feel well, and yet there doesn't seem to be anything wrong." And the doctor runs all the tests, say, "Well, there's really nothing wrong with you." You say, "Well, why am I always tired?" Well, you're getting older. Most of us have heard that, haven't we? You're not 25 anymore. You see? Fatigue is a factor in all of this, you see. And as fatigue sets in, that means then that the muscle can't perform all of the function that it normally performed for us before, and because it can't perform that function normally, and we think we have to do this much work, we push ourselves. So as a result, what do? We're stressing ourselves some more beyond our limit, and we're causing some more of this vicious cycle of strain to set in. And we're becoming even more fatigued. Now, somewhere down here with fatigue is exhaustion. Exhaustion means that a muscle or group of muscles or organ of the body has become exhausted of all of its natural body energy and is no longer able to function normally. An exhausted kidney, for instance, would become a kidney disease. Or first, dis-ease. Remember we talked about that. Dis-ease is the term we use, which is the body against itself, out of ease, not functioning in its normal capacity to function. That can be any organ, any gland, and we could think of the muscle as an organ, but also any muscle of the body could develop an exhausted state and cease to function for us. That then means that exhaustion and pain become synonymous terms. Somewhere in all of this distortion, fatigue, exhaustion syndrome, we develop pain. Now, obviously, we could have a strain caused by a trauma, a blow, couldn't we? And that could be painful. But usually that pain is short-lived, and then we go back to a state of hyperplasia, meaning that we're living at some level of health that we've learned to deal with. Not good health, but a level that we've learned to deal with. Pain and exhaustion and disease, now taking the hyphen out and just saying disease, are synonymous terms. If we have pain, we have exhaustion. If we have pain, we have some kind of a disease syndrome setting up. And we would like to catch all of this prior to reaching a point in that disease syndrome of being able to diagnose it as a disease and be stuck with treating then a disease syndrome rather than just working with the stress, strain, distortion syndromes. That's what we would like to do. That's why our work is called preventive in nature. So now, as we go into our discussion today, we're going to cover first the anatomy of the shoulder girdle so that you can understand what we're dealing with. Then we're going to come back to the distortion syndromes, and I'm going to show you some body mechanics and show you how this then becomes a very important part of what we do as massage therapists or therapeutic body workers. I want to show you on Mr. Bones here the skeletal configuration of the shoulder girdle. Now we speak in terms of areas of the body, and poor Mr. Bones has become so distorted with our demonstrations that any resemblance to anything normal is purely coincidental. We talk in terms of areas of the body, and we'll talk, the next discussion will be on the pelvic girdle. Today's discussion is on the shoulder girdle, and we refer to it as the shoulder girdle of the body. And it's made up of a configuration of bones that are linked together with joints. And what did we call the joint between two bones? Do you recall from the last discussion? What are they called? Articulation. So there are many joints or articulations within the shoulder girdle that we'll cover in a few minutes. What I want to call your attention to, which is really important to know, is that there is only one major, in fact only one articulation of the shoulder to the skeletal structure itself. And that's right here at the sternoclavicular articulation, right there. If Mr. Bones weren't all wired together here, the scapula would flop clear out away, and the shoulder, the acromion, the arm, the femur, and the whole thing would all fall away, you see, and be totally free except for this one articulation here. Most people think in terms of, well, the shoulder blade or the scapula is connected here, back here some way, and it really isn't. It's held in position here by muscle. This gives us then the ability to move this particular joint in such a wide range of motion. I can go clear over here, clear up here, clear down here, back here, around this way. I can do a full circle with my arm. Isn't that wonderful? You see? That's the only joint in the body that allows us to do that. And that's important to remember, is that because it can do that, it becomes a very susceptible joint. It becomes very susceptible to the stress-strain issues that we've been talking about. So we work on a lot of shoulder problems in our clinic because of the way it's constructed and of its vulnerability. Okay. Now show you the ligamentation here. This is the acromion, which is a part of the scapula. And there is a joint or articulation here with the clavicle, and the clavicle articulates here with the sternum, which is right here. Okay? The arm is held in position here via tough ligamentation. Then inside of the joint here is a sac of synovial fluid, which is the lubrication of the joint of the arm. And then there are a multitude of small and very large muscles that allow us to move our arm in this fashion, turning it, allow us to move it this way, and different groups of muscles allow this movement. If you recall, in our last discussion, we talked about the long and short fibers of the muscle and how it gives us control of the speed of the contraction and relaxation of that muscle fiber. And that allows us then to do something as fine as moving our arm very slowly this way and turning the wrist very slowly this way and closing the fingers and having total control of the function of that hand. It's amazing, isn't it, what you can do with it? And to do all kinds of interesting things with your fingers, you see? And yet control the position of that hand and of the position of that arm and do it all quite comfortably and for as long as you need to in any position you want it to go. And this is the body's automatic function of allowing you to control the movement of this limb without giving thought to how many muscles have contracted and relaxed. How many muscles have stabilized in order that facilitator muscles can move. We don't even think about that. Remember what I said. What happens is as babies, we discover the movement of our body. And as we learn what our hands do, we practice as babies closing and opening our hands and finally picking something up and reaching out and grasping. And all of these movements are cataloged, if you want to call it that, are programmed into what? Do you recall? The cerebellum, the lower lobe of the brain. And it's in the cerebellum then that all of the function of all of the muscles is carefully programmed so that when a function needs to be performed, it's almost autonomic in nature. So, but what it really is automatic. So just me wanting to do this with my pointer or point here, it's all just my mind signaling my body that now he wants to move over here. And it becomes such a rapid movement that no thought is given to it. It's just an instruction from my mind to the cerebellum, you see, that says, perform this function. And I give no thought to how many muscles I have contracted and relaxed and stabilized in so doing. And with just my demonstration of moving my arms, my hips have moved, my feet have moved, my legs have moved, and I've stayed in balance over my center of gravity in performing that function. You see? And all of my body is functioning without stress, or at least without stress that is harmful to my body. Stress, as Dr. Selye says, without distress. And I can function this way for a number of hours. Chances are I can stand here and talk to you and you will get tired before I will. You see, because you'll get tired of sitting there where I'm able to move about a little bit and keep my body more functional. Do you see? So as we discuss the skeletal structure of the shoulder girdle, I want you to remember that each side articulates only here. And that's the first joint, the major joint that keeps the shoulder to the body frame itself. So now let's show you on the slides what we want to do now is show you in a drawing the articulations or joints of the shoulder girdle. So you'll have some understanding of how many there are and how they function. We don't want to get so deep into the anatomical aspects of it that we lose sight of the therapeutic things that we intend to do. But it's important to understand the landmarks we're working on. There are 7 joints, recognized joints in the shoulder girdle. I mean 7 on each side. Number 1 is the costovertebral. And I chose to draw this one on the left-hand side rather than on the right-hand side so that you wouldn't get lost in the drawing. But there are 2 on each side. The costal vertebral is the first rib as it attaches to the first vertebra of the dorsal spine. It comes around and attaches in the front to number 2, the costal sternal articulation or joint, which is in the first rib space of the sternum. Articulation number 3, or joint number 3, is the sternoclavicular, and that is the articulation or joint of the clavicle to the sternum. Number 4 is the scapulocostal, and the scapulocostal is a small sac of synovial fluid found at the lowest point, or the most distal point of the scapula, between the scapula and the rib cage. Often overlooked as a joint by practitioners, but never overlooked by someone who develops a case of inflammation or bursitis in that little bursal sac under there, which can happen. It can become very painful all up underneath the shoulder blade, and then you realize that, hey, there really is a joint there. Number 5 is the acromioclavicular. So now the clavicle joins with the acromion. The acromion is the top bone or top portion of the clavicle. And then number 6 is the suprahumeral, and that's where the humerus, or the head of the humerus, comes in contact with the acromion. Now it's important to note that when we raise our arm straight out from us, if it weren't for that joint being allowed to drop down just slightly, this joint would jam. And it does do that in people when they try to lift their arm straight from their side, straight out. This will often jam and pinch in there and become very, very painful. And so we have to work this tissue here and open that up to allow the ball of the humerus to drop away enough in here to allow a separation of the acromion and the humerus. Number 7 is the glenohumeral joint, which is the one that most people presume to be the shoulder joint. Okay, it's the one where the ball and socket, but in this case, that socket is completely open. The socket doesn't go around the ball of the humerus at all, and hence must be held in position with ligamentation, as I showed you on Mr. Bones, and muscle tissue in order for it to be functional. Most people, when they talk about the shoulder girdle itself and the shoulder joint, think that all problems reside right in the glenohumeral part and in the cuff of the shoulder. And the cuff is made up of a group of muscles whose ligaments are attached to the acromion. So now what we'll do is we'll move over and show you first the trapezius. These drawings are all taken from the book that you have, The Illustrated Essentials of Musculoskeletal Anatomy. And this is a superb book, and I recommend it to anyone who wants to understand any of the muscles and the kinesiology of the body. The trapezius is what we term an aproneus muscle. I mentioned that to you last time. It's a very broad muscle in that it attaches at the base of the skull on the occiput and clear down to the last vertebra, number 12 of the dorsal spine. It attaches all along all of the vertebral column and then moves out and attaches to the acromion, and underneath the acromion helps to hold the shoulder blade down and helps to do some of the movement of the shoulder. We call it a triangular shaped muscle, and it forms a trapezium, which is where it got its name. The next muscle is the teres major. Its origin is on the inferior angle of the scapula, right here, inferiorly on the scapula. Its insertion is on the medial lip of the bicipital groove of the humerus, which is just in this area here. Its action is extension. It's a medial rotation and adduction of the humerus. So think about a medial rotation. What does that mean to you? That means if you look at the muscle and remember that a muscle's function is contractual, isn't it? It contracts all of the time. Then as this contracts, it both rotates the humerus and pulls it toward the scapula. So where's the rotation? It turns the wrist forward as it rotates. No, it turns the wrist back. I'm sorry. If your wrist is forward, it turns it back this way. So it attaches to the anterior portion of the humerus, so it has a tendency to rotate it back. We talked yesterday about the levator scapula, and remember I told you that on this muscle there's always a debate as to which is the insertion and which is the origin, because we determine insertion and origin by where the least movement of the skeletal structure is. In this particular muscle, there's great movement on either end. It attaches now to the first 3 or 4 vertebrae of the cervical spine and to the vertebral border of the scapula from the superior angle, which means the very tipmost part of the scapula. And its function is to elevate and rotate the scapula and also to tip the head, to turn the first 4 vertebrae of the cervical spine. The next muscles are the rhomboids, and we consider these 2 muscles, the rhomboid major and the rhomboid minor. The minor attaches, their origin is at C7 and T1, right here.